Welcome to This Just In, the show bringing you the latest advancements in healthcare, strategy, innovation, and public policy. And now, for the fastest voice in healthcare, here's your host, Justin Barnes.
Thank you for tuning in, and welcome to This Just In. I'm your host, Justin Barnes. In these segments, I'll bring you the latest advancements in healthcare, strategy, innovation, and public policy. As always, we're broadcasting from the This Just In studios on the Business Radio X network, as well as the Healthcare Now radio network. For this episode, my 214th episode, we're very fortunate to have two healthcare pioneers and healthcare leading authors, Dr. John Halamka and Paul Cerrato. Welcome back to the show, gentlemen.
Thank you.
Thank you.
It's great to have you here. So before we dive into the book and some of our topics, where are you calling in, John, from?
So I am in Sherborne, Massachusetts at Unity Farm Sanctuary with 300 animals, 22 barns, and 70 acres of biological isolation.
Amen. I love it. So how is that farm going?
Well, it is now the largest animal sanctuary in New England. And the intriguing thing about each day is you never know what the weather will bring. And we, over the last 24 hours, have had this delightful mix of sleet, freezing rain, and ice coating everything.
Yes.
Give me cold, give me snow, don't give me ice.
Yeah, I've watched the weather, and I was thinking about this show, and I was like, oh, I knew you were going to be calling in from that area. I assumed at least, and so I was certainly concerned. But I know your animals are very well taken care of. I actually watched the live video streams, and for all my listeners, I'm sure now through the years you've heard us talk about Unity Farm Sanctuary, but you can live stream it. You can follow you on Twitter, Facebook, all those good areas, right, John?
Yeah, well, exactly. And if nothing else, in a time of stress, watching the donkeys huddled together in the cold or the cows frolic really makes your day.
Yeah, and Dudley. I love Dudley. The updates on Dudley are phenomenal. So
excellent.
And then also the ducks. You have the ducks are on the watering fountain and all that. I just love it. So.
And of course, an interesting thing, someone on TikTok decided that they would tell the audience, oh, go buy a duck during COVID. It will be wonderful in your apartment. No. It turns out not so much.
Not so much.
So an animal sanctuary in your region will be happy to take the ducks from you. We have received 45 COVID ducks over the course of the last year.
Wow. So, Paul, where are you calling in from, my friend?
I'm in Warwick, New York, and that's about 60 miles northwest of New York City. And there are no animals here, but there's one very, very warm wood stove that I'm enjoying.
There you go. Excellent. And what's the temperature there today?
About 35, actually. We had 2 foot of snow a week ago, but now it's starting to clear up.
Okay, because we've had a big cold snap. So I know there was some parts that dipped way down, but actually sounds pretty temperate. Actually, I think you might be warmer than Atlanta today than Paul. Wow.
Yeah.
That's impressive. All right, so let's dive in, gentlemen. Now, is this your 5th book together, 6th book together?
Number 5.
Number 5.
Yeah.
Excellent. So let's start off. I love the dedication, and so let's dive into that. But here's the dedication. There are rare moments in history when technology, policy, and urgency to change coverage or to change converge. This is one of those moments. So let's dive into that a little bit, because I actually completely agree with you, John, but just dive into that a little bit. Why that?
Well, sure. And so think about it for a moment. Before COVID, people said, oh, well, there's telemedicine and virtual care. You know, it might work, but just think of how impersonal it might be. And really, it won't be reimbursed. And it's a change, and change is hard. We went as a society from January 2020 with 3 or 4% virtual care to April with 90% virtual care.
Right.
And we did it because we had to. There was no alternative for on-prem care at the beginning of a pandemic. What has that meant? It meant that cultural expectations for care have changed. And that people are saying, well, it works so well. Why would I want to drive, pay $40 for parking, and then sit in a waiting room of people coughing on me? I want more digital healthcare. And that cultural change has been even more important than technology and policy change.
I completely agree. I even was reading the Wall Street Journal this morning regarding even banking. I don't like when people compare healthcare and banking, but this is a little bit separate. They actually talk about how the European banks, the people would never change. They wanted their local branches. They were not going to change. Take on technology. They want to walk to their bank, do their banking in person. But now COVID has forced them to change and evolve, and now they can become a little bit more, better substantiated businesses. Because right now their ratings were poor, and it forced a lot of change over there in their banking system, and I'm sure a little bit on ours. But it was a significant change where I think 35% of banks are now going much more virtual and being able to streamline their operations. So on top of what we've done here, certainly in the country, and I think we've stabilized now around 20% of care is still going to be done via telehealth. Is that what you're finding, John and Paul?
Exactly. 20 to 25%. It depends a little bit on the specialty.
Yes.
Because certainly we found that most medical visits can be replaced with a virtual visit. But then when you think of post-op checks or surgical visits, it's just a little bit trickier. And, lest you think, oh, I can't do an abdominal exam virtually. You actually can. If I say, hey, Paul, would you push for me on that area just to the right of your belly button and let go and let me see the expression on your face? I can tell you if a person has appendicitis and they push on their right lower quadrant, they will grimace.
Yep. That's excellent. Very, very good point. So before we dive into the book, you both now work at Mayo Clinic. You've been there for how long now? A year and a half now, John, personally?
January 1 of 2020.
Okay. Wow.
So it's been an amazing first year.
Yeah. So why don't you describe your role as president of the Mayo platform? Is that and then John, you talk about, then Paul, you talk about your new role. But
Well, absolutely. So here was the notion that Gianrico Ferrugia, the CEO of Mayo Clinic, posted a job description in August of 2019. Wanted physician, engineer, 30 years of digital transformation experience, extensive knowledge of national and international policy and economics, willingness to travel, and interest in speaking and writing. Now, it turns out that phenotype is slightly rare.
Yeah.
And the notion was this: if by 2030 we're going to see much more virtual care, much more in-home diagnostics, data of the past being used with algorithms to deliver the best, safest, and highest quality care to patients in the future, how do you build the infrastructure, the teams, and the processes to achieve that? And so hence Mayo Clinic platform was born. And the notion is, think of it as a very advanced Lego set. The idea is you're creating components and processes and people that can be assembled in novel ways to provide revolutionary healthcare delivery, whether that's high acuity virtual care at a distance, AI algorithms that are ethical, running in a continuous way, keeping you healthy, or novel ways of ethically, in a privacy protecting way, using that data of the past to develop new cures and treatments. And that's what I do today.
That's phenomenal. How large is your staff?
So are you familiar with the Jeff Bezos 2 pizza rule?
Yes, I love it.
So although Mayo Clinic is 70,000 employees and affiliates, and I can leverage the shared services in marketing and public affairs and IT and legal and such, the actual team for platform is 30. And I like 30 as a number because you can be very agile with 30 folks who know each other so well. We know our kids. We know what's important to us. We know our values. It's a lot easier than anything much larger than 30.
Yep. No, I like it. I've actually just brought up some of those tenets, his leadership tenets, to one of my companies last week, just around, being prepared for meetings, brevity of meetings, not having too many meetings in one day. I think actually he doesn't start meetings before 10 a.m. And then he also does the real high quality visits as well, meetings as well. Intellectual. No, what's the term? Is it intellectually? There's a term he uses. for some of his leadership. But it's great. He has like 5 main tenets. This was in the Wall Street Journal last week, actually.
Got it.
So it's excellent. So Paul, tell us about your new role, my friend.
So I'm one of those 30 people on the platform, and my official title is Senior Research Analyst and Communications Specialist. And I guess the best way to describe what I do is to talk a little bit about some of the projects that I've been involved in since I came on board last month. John and I are co-authoring several blogs on his website. His website's called Dispatch from the Digital Health Frontier. So we've tackled issues like racism and how data analytics can help with that. Wearable danger is another one we've done, which talks a lot about how easily hacked medical devices are.
Yes.
And we've done some cutting edge stuff like speech pattern analysis to help with the prediction of heart disease. And then the second thing I'm involved in is in April, Mayo is hosting a data privacy conference. So I've been asked to take the content lead on that, put together some background information and help organize the conference. And then finally, the thing that I'm probably most excited about and most proud of is that John and I recently had a paper published in the New England Journal of Medicine, same topic as the book, which is the Digital Reconstruction of Healthcare. So I've got a full plate.
Wow, that's awesome. Excellent. I bet you every day is extremely exciting. It's pretty informative as well.
Yeah.
So let's start off, before we dive in deep into the book, let's do a little bit of a level set for my audience in the industry. And I'll ask you both this question. Is there, and this, I know it's a tough question, but is there a common set of tools or innovation where the average healthcare organization can start their virtual care journey? And I know this is some opinion here, but I'd love to get your expertise. So John, we'll start off with you. What are some of your thoughts there on a common set of tools for the average healthcare organization in America to start their virtual care journey?
And the answer is sure, there are many tools. It's very confusing to navigate. You'll look at the vendor space, and there are many leading companies in the virtual care area. So the idea of a platform, this Mayo Clinic platform I lead, is to say, aha, here are the modules that Mayo has used, but modules that are available for other organizations to use as well. And many of these modules are developed with companies in the industry. But the idea is that we can help you navigate to that virtual care future because we have had a lot of experience about what works and doesn't work, and we share very openly those experiences we've had. So think of it this way: you need technology and you need a navigator to help you get to this next virtual care nirvana where all healthcare organizations need to be over the next decade.
What is it? Would you say navigator? What does that mean to you?
Oh, somebody who's been there before. So Paul knows because he reads everything I write on a weekly basis. I said some of the innovation that's happening now is like navigating without a map, which is we don't really know where we're going, but we're pretty sure it's the right direction. And so what you'd hope, as you say, other healthcare systems that may have fewer resources or less of a risk tolerance or ability to fail, should look to those navigators who've already traversed this journey and can say, "Oh, don't avoid the quicksand; it's over there."
That's terrific. So, Paul, what would you add on to that? Or what are some of your thoughts there for a common set of tools?
I mean, ideally, providers should have a sort of a consumer reports database where they can just type in a particular vendor and say, is this tool useful? Is it evidence-based? Right now, we don't have that. So in lieu of that, there are some guidelines available that clinicians can use to help determine what works and what doesn't work. Recently, I've participated in a clinical decision support summit, which was hosted by Roche and a few other folks. And they put out a series of basic guidelines. We talk about it in one of our blogs. It's a blog on John's site called How AI is Impacting Healthcare Today. and it lists some of those guidelines. There's also the FDA. They have a list of approved AI tools, which is a kind of a minimum level requirements for any healthcare provider to think about. There's also a group of international clinicians and researchers that have put together something called the Spirit AI Initiative. Basically, that's a list of what you need to do when you publish quality research on AI and machine learning. So when a provider is thinking, is this tool worthwhile, they have to look and say, okay, are they following the basic criteria? Are they using prospective studies as opposed to retrospective studies? Is the data set biased, and so on and so forth? So there are criteria available. It's not quite at the point where we can say, okay, there's a consumer reports database and we just plug in the name of a vendor. It's a little more legwork involved, but it's a beginning.
Yeah. So let's dive into that. This is, coming from some of the table contents of your book, The Digital Reconstruction of Healthcare, Transitioning from Brick and Mortar to Virtual Care. So let's dive into the AI and machine learning that you just brought up. So how is AI and machine learning helping us cope with COVID-19? You want to take that, Paul or John?
Well, there's a research project that was published recently that looked at huge data set of research papers and EHR patient records and whatnot to figure out, well, what's the earliest signs and symptoms of COVID? And these days, most people think of the flu-like symptoms, cough and fever and so on. But the results of this AI-fueled study was that the earliest signs and symptoms are loss of taste and loss of smell. So that in itself set us in a whole new direction. And this study has been supported by others. So that's a piece of info that's very practical and useful.
And so what it shows is that an AI model looking at millions of patients, and it's a statistical probabilistic model, right? It's not necessarily deterministic or causal, but what you can see is that if you've lost your sense of smell and taste, you probably have COVID. If you wake up with a fever and body aches,
right,
pretty hard to know.
Yeah.
Doesn't really mean much. And so that's certainly looking at signs and symptoms and then diagnosis has been a very successful AI model.
Yeah, and I'll say that was one of my main reasons why I've tried to stay healthy over the past year with since the advent of the pandemic here, because I'm a foodie and taste is just so significant. The older I get, the more I get into food. And if I ever got COVID and that happened to me, I would be quite upset because it would change my life actually dramatically, is the loss of taste. Yeah. So let's talk about or discuss some of the AI and machine learning shortcomings. I mean, we've talked about this in previous shows. You guys are pretty much experts on this. But talk about some of the bias contributed disparities of care and digital divide and so forth. So let's dive into that. John, you want to take that or Paul?
Sure. Why don't I start?
Okay.
So what if we took, I don't know, 1 million Scandinavian Lutherans? I'm making up a Minnesota example.
Yes.
And we created an amazing model for some disease diagnosis or treatment plan. And then we used it in Spain.
Right.
Is that going to work? Maybe. Too little care, too much care? Don't know. Or what if, again, just thinking of a model here, we say we're going to convert Apple Watch data into diagnoses. Okay, well, the population that went into that study would be people who own Apple Watches. And so you worry about bias.
Mm-hmm.
You worry about I described an algorithm as having an ingredients list, what data went into it, but also a nutrition label. What purpose should this algorithm be used for? Where is it healthy, so to speak? And you need both. And so what Paul and I have thought through and we're working on at Mayo Clinic is how for every algorithm we produce, can we make some statement about how it was created and how it should be used? And it's okay to have an algorithm based on Scandinavian Lutherans if you're using it on Scandinavian Lutherans.
Right.
But you need to be clear about that. And that's a body of work society needs to do.
Yep.
Yeah, and the same problem applies to people of color in the United States. A lot of the databases right now have collected information about white males. Obviously, you can't apply that in a population that has lots of Hispanics and blacks. So we need to be aware of the biases of different data sets and correct them.
So I completely agree. So diving into that, what about the computer models realistically reflecting the real world? Because how do we ensure that, or how do you manage that?
One of the lines that we often say when we give presentations is machine learning algorithms can't replace an experienced clinician's diagnostic and treatment skills. And that seems kind of obvious, but there are those who are so enthusiastic about technology that they think it's possible. It's just not going to happen. One of the statistics that we included in the book is an analysis of about 80 studies that looked at the diagnostic performance of deep learning and compared it to the diagnostic performance of healthcare professions. And overall, the models found that the skills of computers were about equivalent to the skills of health professionals. But when you dive a little deeper and look at the sensitivity of those algorithms, it ranged from 10% to 100%, which means some of them are absolutely junk and some of them are quite good. So once again, you really have to be discerning. And one of the goals we have at Mayo Clinic is to help docs and providers learn how to be discerning, how to be discriminating.
And Paul has said it well. It's a combination of algorithm development and validation. And so one of the things we often do at Mayo Clinic is we will deploy an algorithm internally that is not used for decision-making or clinical care. It's simply sitting there passively, showing you a result. And, you can say, oh, well, I've seen this now for the last few months, and it has actually worked pretty well because it's being validated on a different set of patients than were used to train the algorithm itself.
So when you touch on this, in the book, what's the main goal? I mean, you're educating, but who do you hope the reader will pull from this? And how do you expect them, or how would you want them to modify their actions, behaviors, strategies?
John?
Well, Paul, I want to just start with one thought, and that is we hope that people understand that AI algorithms aren't magic, and AI algorithms are a mathematical construct that, when used appropriately, can be extraordinarily powerful. I mean, we cite examples in retinal scanning or in telemetry analysis where, in fact, an algorithm appropriately trained and validated can be better than a human.
Yes.
But, again, just need to be very careful. Maybe it's a bit like when you buy something on Amazon, you see products that are 1-star and products that are 5-star. And what you hope is with AI, we get to that point where there's enough knowledge about where they're good and not, and who uses them for what, they will in effect have consumer level ratings that will help us choose the right algorithm for the right purpose.
Excellent. Anything you want to wear on there, Paul?
No, he said it well. I can't think of anything to add.
So we have about a minute or so to close out this first segment. Then we're going to dive into we'll certainly look forward to our second show here in a bit. But John, if you can give a little bit of a crystal ball look into, and we'll cover more topics here, but tell us something that you're looking out for in the next 12 to 18 months in healthcare and digital health.
So I'm thinking, especially in this time of COVID and post-COVID, that we're going to see the emergence of many home diagnostic tests. So today, I mean, I'm dating myself here to a child of the 60s. When you were worried about pregnancy, there was a test and there was this expression, the rabbit didn't do so well. Well, today you go down to Walgreens and you pick up a lateral flow assay, and within a moment, you probably have an electronic indicator that says pregnant or not. Well, we're going to see this emergence of lateral flow assays in the home and apps on the phone that interpret rapid diagnostic tests. So there'll be far more diagnostic testing at a distance. I say this because if we're moving virtual care to a distance, we're also going to need to take the digital signals and diagnostic laboratory tests and move them at a distance.
That is excellent. That is excellent. And for the sake of my audience being upset with me, I'm actually I think we should hold it there. And when I'm going to basically a cliffhanger, because I've got a couple of great follow-up questions, because this really does lead us very well into where we're going with virtual care. So the home-based models. I know our next show, we're going to dive into the home-based models as well, but also just the evolution of where we see virtual care going in the next 6, 12, 18, 24, 36 months. So stay tuned, everyone, for our next show. Very excited. You guys are always phenomenal guests. I look forward to recording our next show here shortly. But gentlemen, thank you very much for taking your time out of your busy days to join us. And I will know you have you back here shortly. And everybody, please join in next week. You can hear the conclusion of my conversation with Paul and John about their new book, The Digital Reconstruction of Healthcare, Transitioning from Brick and Mortar to Virtual Care. And I'm sure we'll have a few more sneak peeks into the crystal ball. And thank you, everyone, for joining us today. As always, you can track me on Twitter at HIT Advisor and use the hashtag ThisJustinRadio so we can respond to your comments from the show. If you missed any of this episode or want to hear more, all my shows are posted on Apple iTunes, SoundCloud, iHeartRadio, Spreaker, Google Play, and TuneIn. Also, you can check out the updates that we just launched at justinbarnes.com. Thanks, everyone, and stay safe.